joining us online. Everyone in the room is enjoying.
Before you came in here today.
Chinese lunch is our theme today. But we have a dynamic presentation, a panel here that is going to enlighten us, and we have Dr. Stripes. I'm here to assist us in the moderation, and we'll take it from there.
Okay, so we'll try and talk about, again, the speakers will have a mic that we'll pass around. So I'm Lafond. I'm a nurse practitioner and the clinical director of the Panda Palliative Care team, and we have a panel today of very esteemed integrative therapists from a wide variety of practices. And so what our goal is for today is really for them to talk a little bit about the modality of integrative medicine that they practice, what is sort of the rationale for use of those modalities in patients, and then an update on the current research, as you are aware of it, in your modality, and how can we think about engaging patients and families, and I guess other staff in researching these areas of integrative practice. So I'm going to ask each speaker to introduce themselves, because you know way more about yourself than I do, but I am going to introduce our first speaker, who is Dr. David Steinhorn. He is the medical director of the Panda Palliative Care team and comes with a wealth of information on a variety of integrative therapies, and I'll let him tell you more about himself. Dr. Steinhorn.
All right, is this on or not?
You have to turn it on. Okay, there you go.
I'll turn up the volume. No? Yes? No? Whatever. It's okay. I'll try and speak loudly because with my presbycusis, I tend to speak louder than I should otherwise. I'm told by my wife and children. So I want to give you, I heard I had 5 to 7 minutes. I want to give you a little background. I'm critical care attending since the mid-'80s, palliative care attending and pioneer in pediatric palliative care since the mid-'90s. And I come out of a bioethics background in the mid-'80s at the University of Minnesota under Art Kaplan, who is the ethicist who gets interviewed by public radio all the time. And I thought ethics would help us make decisions and help families that were suffering and struggling in the ICU. It became clear that that was a lot of fancy words, and I lost interest by the mid-'90s when pediatric palliative care was beginning to be an entity and separate itself from adult hospice and palliative care medicine. So I became a proponent of pediatric palliative hospice care and saw that develop. But I realized that we needed some other way to help our families to touch the patient in a way that words and cognitive kind of behavioral therapies don't actually touch them, in order to help move families and patients along a trajectory of either getting better, if healing is what was meant to occur, or to find a way to end their lives if that's what was meant to occur. And so by the 2000s, I was at Children's, or Lurie Children's it's called, in Chicago, and we had a $1.8 million grant from a philanthropist who wanted us to investigate integrative therapies and how they would fit into the pediatric healthcare system. And so we spent 8 years spending that money, but had a number of publications and chapters looking at energy healing techniques, which you can think of as Reiki or healing touch or therapeutic touch as generic categories. We looked at massage therapy, and we looked at acupuncture. We did not look at Chinese herbs at all because herbs and supplements becomes a hot button topic amongst Western healthcare providers. So a lot of the work grew out of that. And from that work then grew also work in the direction of what does it mean to support the human spirit? With the concept that if we support the human spirit, it allows the body to accept Western medicine more effectively. That's the overarching thesis of the work that I've been doing for the last 10 years. And Vicki is the mindfulness expert. You know that already. But you know, there are a number of avenues to mindfulness. Wait. So look at this slide. 5 things you need to know about mindfulness, Vicki. That you can be focused on the outside or focused on the inside. And when the thinking goes up, your mindfulness goes down. But our families find themselves all wrapped up in their inner thinking and their inner dialogue because they're in crisis. I believe that parents are often in victim mode the victim of the illness of their child, and so it's very difficult for them to get out into a more calm, level, balanced kind of place. And we don't have words when we're in this inner mindful state. And any one of us, if we were to do a little experiment for a brief moment, most of us, it can only last for a few seconds at a time, don't you think, Vicki? That just for just a few seconds, you go to a place where you can have no talking, and you're just aware of being there and the weight on your feet, etc., and being present. That's kind of being mindful. And it'd be great if we could stretch that out, but I don't believe it's the destiny of normal, everyday human beings to live constantly in a mindful state. That's the goal of monks in monasteries and for other people of that sort. And mindfulness, as we apply it in Western culture, really has to do with being able to come back to ourselves in a reliable way and be present without all of the anxiety and the inner dialogue going on. And the question is, how can we help families to find that mindful state in the midst of anxiety and fear for their child's life or these sorts of situations, especially families who have had no exposure to meditation or to mindfulness training or to any other of these disciplines, maybe haven't even spent time in deep prayer. And maybe when they go to church, they just read the liturgy and that's it, and it doesn't really connect with an inner feeling of connecting to something greater. So all the work that I've been doing has been to try and find a way to help families knowingly or unknowingly connect with something greater, and in that greater place to access information that may help them in making decisions on behalf of their children. I think that's pretty clear. So we began this work back in Chicago, but I really got into it when I went to Sacramento in 2012. And worked extensively with a number of different healers that go by the names of shamans or shamanic healers. Some of them were the Hmong shaman, the ones that they wrote the book, The Spirit Catches You and You Fall Down about. I had quite a number of very close and trusted collaborations with them that I would bring them into the ICU and say, Jenny, tell me what's going on here. And she'd give me insights that would help me in my conversations with the family, and 8 or 9 times out of 10, the insights were so accurate and useful that it helped facilitate the further discussion dialogue. That's for discussion over beers. We've done this work in a number of different places in the Northern California area, and we've even done some of this work. This patient over here is a traumatic brain injury at Children's National. The first year I was here that we worked with in the ICU. So this is a little video clip I pulled 1 minute of an 8-minute public television.
Pediatric intensive care units are typically jam-packed with the very latest in modern technology. Dr. David Steinhorn uses all that and more to save young lives.
Often healing really is allowing the parents to understand that life continues on in their heart, in their mind, to be able to bring that forward to parents, heart-to-heart talks with them, is some of the most powerful healing work that I've had the privilege of assisting.
It's almost a foregone conclusion that there will have to be additional approaches to healing than simply more and more allopathic medicine and Western pharmacologically based therapies. All right, so this is the overarching concept. We've done dozens of cases in Northern California, and we've done probably half a dozen cases here.
Yes.
So what the result of this is that this is a family with an infant who had infantile Gaucher's, where he was losing milestones by 6 months and weak, and he was seizing by 9 or 10 months of age, trached and ventilated by 10 months of age, and then ultimately his family wrestled with the question of how to make a decision for him. And what I think that this demonstrates in the mother's own words is that when she was able to go to a quiet place through the assistance of the healer who worked with her out in the rehab center in California, that then she was able to actually, whether it was from her own mind or from her child's soul, hear what decision she felt she needed was proper for the child, which was to allow him to die in a controlled fashion and discontinue artificial life support. This is a very elegant kind of demonstration of that benefit. So the conclusion and takeaway is that helping families and patients find an inner quiet state allows more heartfelt and less emotional decisions. Patients who cannot verbally communicate integrative modalities may be useful to provide comfort and reduce stress. I mean, how do you help? We know how we help somebody who's a 32-year-old who's conscious and has advanced cancer, a 43-year-old mother who's got 2 children at home and found out that she's got some advanced malignancy and she needs to make decisions for herself. We know how to talk to those people. We can use words and we can use cognitive kind of interactive ways of helping them make decisions and decide about things. But what do you do for the patient in a coma after traumatic brain injury in the ICU? How do you help them resolve their life issues? If we assume that every one of us at each stage of our life has unresolved life issues, then why would those life issues stop being issues just because we're in a coma? Or just because we're 3 months old and we can't talk? Or just because we're 75 years old with advanced dementia and we can't communicate verbally? And so the real question is, how do we touch the inner human being through modalities that would fall under the rubric of integrative modalities, massage, acupuncture, this sort of spiritual shamanic work at that level, working with a drum, working with a rattle, these sorts of approaches. How can we use those then to help families communicate, as I call them, and using nonverbal methods? And then my goal is always to think outside the box, because conventional medicine has not answered all the questions we have. Thank you.
All right. Thank you. We're going to have questions from parents, so that all of our panelists can talk. Thank you, Dr. Steinhorn. Reese, we're going to have you speak next. And Reese is our acupuncturist and acupressurist. I'm sure there's some more fancy terms for that.
Doctor of Chinese medicine.
Yes. Yes.
Oh.
What do I do? You can stand up or sit. Just cough loud.
Okay, I'll stay here. Hello, I'm Reese Idiotitas, Doctor of Chinese Medicine, as Dr. Steinhorn pointed out. Under the umbrella of Chinese medicine, the main modality that I do here on the Panda team is both acupuncture and acupressure. I've been practicing for almost 12 years. Wow. And been here at Children's going on my 3rd year. Right? Mm-hmm. Yes.
Right.
And doing pediatrics specifically for about 7-ish years now. And as far as research specific, the history of kind of acupuncture and research has always been a little difficult, because acupuncture is such an art that trying to kind of fit it in the box of clinical research is just tricky. Finding the balance of having the flexibility to stay true to the art of being able to like truly treat every patient as an individual and not as a disease or as a symptom, and yet trying to follow the protocol that's given within whatever study is always been very tricky. So, for example, if I was having a patient with a migraine come in, 2 patients presenting with migraine who kind of on the surface might be presenting very similar, but because one is constipated and not only are they not sleeping well, they tend to wake up around 3 a.m., they're going to get, bringing the art aspect of what I do, they would get just a completely different treatment than someone who's even waking up at, 6 a.m. regularly. So trying to work that into a protocol that we're researching to see if acupuncture works for migraines is always presented some difficulty. But we've been making it work, and there's tons of research lots of different research studies that have been done, and with good results. Something else that as a acupuncturist and research are trying to address is, so not only does the art aspect come in and, how do we do this research? Every acupuncturist, being an artist, does their art different. So, again, within research, me treating a patient with migraines, not only is my actual treatment going to be different, but, like, my style as far as, like, what my hands are doing, what I'm doing with the needle, how far am I inserting the needle, how much am I manipulating the needle, what's my intention with this needle is going to be so different than another acupuncturist. So kind of standardizing and trying to encourage more within publication of research, including that information, not just I use this large intestine 4 points, but I use this large intestine 4 points with this much insertion, with this much stimulation, and retain the needle for this much time, which a lot of studies are lacking, and actually for that reason a lot of acupuncturists, although we look at the study and might find it very interesting, don't necessarily take what's in that study and then change our practice because of the results.
What modalities do you find acupuncture and acupressure useful for? What kind of things can you use it?
My generic answer is anything almost that you would seek a medical professional for, you could probably consider acupuncture for. So there's such a wide, so I have patients here in the hospital, and I have what I say, my typically healthy patients that aren't in the hospital, where I'm treating things, just as simple maybe as some acute constipation, ADHD, anxiety, because of some like insomnia. Right now I'm getting all my seasonal allergy patients who I see kind of annually at this time for several weeks until they're like, yep, I'm good, we'll call you next year. And then here, obviously we've got the palliative care patients who mainly treating symptoms of their bigger picture of what's going on, helping with their nausea, helping with their digestive motility, helping with their anxiety and just general feelings of like breathing and feeling comfortable in that moment. Huge range.
Great, yeah. All right. I'm sure we're going to have more questions for you in just a few minutes. Marian, I'm going to actually go next. Marian is an expert in several different integrative modalities, aromatherapy being one and healing touch being another. So, you want to introduce yourself?
No. At the bottom? No. I said some G's. Yeah.
Do you know where they're at?
Okay. So,
You want to introduce yourself? Yeah.
So my name is Marian McEvilly. I've been here since 1983. Everybody has this life-changing moment when we kind of go to what some people refer to as the dark side. So I went to the dark side about 11 to 12 years ago. I became very interested in many modalities and went down the path of lots of those modalities. So
why is this the dark side? Maybe it's the light side.
I think it's the light side, enlightened side, not light side. A lot of people say it's the woo-woo side. That's another talk I give, woo-woo medicine versus integrative medicine. But so I went down the path of learning many modalities. I'm clinically certified aromatherapy. I do EFT, emotional freedom techniques. I am a master Reiki practitioner. I have done healing touch. I'm a healing touch apprentice, and I also am an advanced practitioner in energy medicine and everything else. I forget what I've gone down and so. But what I use at the hospital mostly is aromatherapy. Aromatherapy has become my most passionate use, as well as EEM medicine. And what Reese was talking about is each patient is different, is because you have to follow the energy, where the energy flows, and where is the blockages, and that's how she knows, that's what she calls her art form. And so I follow the energy. So I did a study on post-op nausea and vomiting using aromatherapy, and we just completed that study, and we have a poster ready for the research week. But most important, I would like people to know about the sense of smell, and a lot of people just say, oh, aromatherapy, I love the smell, and they don't put any thought into aromatherapy. And sadly, aromatherapy is out on the market, mass market, all over the place right now, and it's going to cause a lot of problems. Because a lot of the aromatherapy is not true aromatherapy. It's all, everybody wants to make money, so they're going to adulterate it. And so when we breathe in things, and if you just shut your eyes and even think about someone handing you a bouquet of roses and breathing in the smell of roses, you will all of a sudden start to feel good. So the aromatherapy and the smell can raise your vibrational energy. The reason we want to raise vibrational energy is because if you're sad, depressed, you're in a hospital, you can't sleep, or all these factors, we want to lift you up to make your body feel better. So smell also works through, as we know, through our nose and into the olfactory into the limbic system. The limbic system is, how do I go forward? Push enter. Enter. So this is one of my biggest fights that I have with people is the limbic system is the biggest memory evoker. And so if we're diffusing lavender in a hospital, then when they leave the hospital, what are they going to, every time they smell lavender, what are they going to remember? Hospital. So I would say, okay, let's use essential oil. It has a similar organic chemistry chain as lavender, and one that's not so familiar to them, and they won't have that lavender trigger. So lavender has the same organic chemistry chain, similar organic chemistry chain, not the exact same, similar organic chemistry chain as Valium, and the mass market knows that, because lavender's in everything. We're such a stressed society that we need the lavender to help relax. And when residents or fellows come to me and say, I can't sleep, I have them diffuse with lavender. And if they come back and say, I slept great, well, we know they're stressed. If they come back and say, I can't sleep, then I'm thinking, okay, let's give them an oil to diffuse. That triggers melatonin, triggers the pineal gland to release melatonin. If they come back saying they can sleep, then I know they have a problem with their pineal gland. So essential oils have great uses in a hospital. I like to combine lots of different oils together. A lot of research studies are with peppermint and post-op nausea and vomiting versus alcohol. Well, alcohol is not an oil, so I don't know how you can compare apples and oranges. Or they might have a ginger and alcohol. So I combine 4 different oils together. So lots of times I like to think about combining 4 oils is because no one can pick out one exact scent. It's like having a mixed drink. You can't figure out which drinks you're drinking, I guess. I don't drink, so I don't know. But so that's why I like to mix essential oils when I'm either diffusing or using in my study. I meant to bring this up, but I didn't have time to go to my office. So I like to use a little packet that is pre-made. The oils are dripped onto a sterile surgical sponge that's in a little packet, and the kids smell it. When I first was introduced to this idea of distributing the essential oil that way, I was like, oh, this isn't going to work. But I have come to love it for a hospital setting. I went to VCU and talked on clinical aromatherapy with the nurses down there. They were putting essential oils on a cotton ball. Well, how do you control that? And, you know, kids with a cotton ball, where's that going to go? Who knows, right? Or somebody who's disturbed, or, you know, mentally ill person, or an autistic child, you don't know. So this packet is controlled. It can't be broken into. They can't really rip it with their teeth. And it's good for over 3 months. They can take it home with them and enjoy it. So I really love that way that it's delivered. Also, I believe in diffusing as well, but that's for a separate talk, a separate section. But I'm really can find great use with aromatherapy, and if anybody has any questions, we could save it for later. Was I too fast?
You're good. All right.
Great. Okay, thank you.
All right, thank you. Here, I'm going to have to talk about massage.
Hi, I'm Carrie Jordan. I'm the operations director for Healwell, and we contract with many hospitals and care facilities to provide massage therapy to inpatient and outpatients. I am super fond of saying that this is the surface of my brain, and when I press the surface of my brain against the surface of your brain, all kinds of amazing things can happen. And I'm really excited to sit on this panel with you guys because I think we have a lot of overlap in what is hard about research about these modalities is exactly what Reese said, that just like acupuncture, just like aromatherapy, just like mindfulness, the individual is really running the show. And so it's very, very hard to design a protocol for something like massage therapy that accurately reflects what massage therapy is, because I am going to do something different with every single person. And the way that my colleague works with the same person is going to be different than the way that I work with them, even if we are both doing 4 long Swedish strokes, 3 gentle compressions to the big toe, right? It's just not going to be the same. And so that is both what's beautiful and exciting and challenging about the kind of work that we do. And so in terms of research and massage therapy, I think this is one of the challenges, because I think right now the world of massage therapy research is really anchored in an obsession with the mechanics of massage therapy and mechanistically what is happening when I give you a massage. And I personally, and I think we at Healwell would agree that this is kind of a red herring and isn't really what is powerful about what massage therapy can do and be in a clinical setting. There is tons of research, good research, solid research that shows massage therapy reduces pain and anxiety. What we don't have, and what we at Healwell we're completing right now, a very large dosing study that we believe is the only one of its kind for massage therapy. You know, what we've heard is, we've shown massage therapy helps reduce pain and anxiety, but only temporarily. Well, morphine works only temporarily also. Nobody thinks I gave this patient 1 dose and then their pain came back. That was useless, right? But I feel like this is one of the things lacking in lots of integrative medicine studies. And so what we are really passionate about and trying to advocate for in massage therapy research is longer-term studies. What happens if you get a massage every day the whole time you're in the hospital? You know, what happens if you get a massage every night if you're having trouble sleeping before you go to sleep? And what happens to your sense of control if somebody in scrubs walks into your room and you can say, no thanks, and that person just says, okay, and walks out, right? That's especially in children, it's a really rare occurrence for these patients. And so how do you feel about your control, about your own care, is something that I think is really important as well in what we do. That's all right, enough time, I did.
I'm volunteering for the massage every night. First one on the list. There's a wait list, actually. All right, so I'll be on there. Vicki, have you talk about your work?
Okay. So I'm very much interested in mindfulness. Mindfulness-based stress reduction is has anyone ever heard of that? A program I stumbled upon when I was back in school about 8 or 9 years ago. I actually went back because I wanted to learn how to design research for my patient population that didn't really have any research done, to find a non-pharmacological way of helping them manage our adolescent patients. I'm sorry, I'm in cardiology. I'm in electrophysiology again, practice nurse in cardiology. So I work with kids who have arrhythmias, cardiac devices, pacemakers, defibrillators, and many of them struggle with anxiety. They live with fear of sudden death. What if I get shocked or my device stops working? Not to mention I have this illness that could make me
die at any time. And I'm different from all my peers. So when I was back in school, I found this program called Mindfulness-Based Stress Reduction, which in the adult, it's a decades-long now studied program in the adult world, very well studied, great, high-quality, randomized controlled trials used in adults, many different populations of adults, cancer, headaches, heart disease, chronic pain, anxiety, and had very, very positive outcomes in the adult world. And so but in pediatrics, it's a very emerging program. So it uses meditation, all different types of meditation, yoga, group support, and the beauty of it is that you can tailor it to any population that you're working with, whatever their chronic problem is they're dealing with. So I took this program and modified it. I wanted to do a 6-session program with our adolescents with cardiac devices because they don't have the same attention span that adults do. So we shortened the program to an hour and a half instead of 2.5 hours and 6 sessions. We did it on Saturdays so the kids could get here and not have to worry about school, and parents could get them here. And first wanted to see if it was feasible. Would the kids show up for this program? Would it help them? It turned out that it was feasible. Our first pilot group, we had 10 kids, 100% completion of the study, significant decreases in anxiety, significant improvements in coping mechanisms. And they formed a nice little solid support group for each other. So that was good. We thought it was feasible. So then designed another study that was a randomized study. We had almost 50 kids in that one, in the next one. Half the group got the same intervention, and the other half was just an online support group that we met weekly for 6 sessions. And it turns out that both groups had significant improvements in coping, but the mindfulness group talked about, oh my gosh, how meditation can help me when I'm feeling palpitations, when I'm anxious, when I'm in the moment, and using these skills to help them cope in their daily life. So that was the next one. And then we decided that we wanted to take what we've learned from this. The science is showing more and more. You see mindfulness all over the place. Now you see meditation all over the place. It's come so far in the scientific world from where it was 10 years ago. In the neuroscience world, they've shown that meditation, even short programs of meditation, 8 20-minute sessions, can improve your immune function, can increase the gray matter in the good parts of your brain that help you with emotional regulation, with empathy, with compassion, with learning and memory. And it can also decrease the gray matter in your amygdala, which is your stress center, where your perceived levels of stress come from. So on MRI, you literally see these physical changes in the brain and the changes in the neural regulation system. So it has, in medicine here, we're all talking about how we struggle with research and how do we prove these things. Like when you know in your heart this is making a difference, but how do we prove it? How do we show it? And that's how it's going to gain credibility in the medical community by showing these effects. So we took meditation as a very big part of mindfulness, and we decided that we wanted to develop a program, a larger scale program that will help more of our patients learn how to deal with stress. But in order for us to help our patients deal with their stress better, we have to learn how to deal with our own stress better. We have to become more aware as providers and as individuals. And so we designed a program called the Mindful Mentors, which we actually just finished our first cohort. It was a 12-month program. Started off with 16 hours of intense training in different meditation techniques and different mindful communication techniques. We have a few mentors in the room here. And then we had monthly meeting sessions where we did debriefing. The other part of this program is it was a train-the-trainer approach. So we were training the people who participated in these techniques to use for themselves, but also then how to bring that to other staff on their units, and then how for them all to bring it to the patients in small ways and large ways. So we just, like I said, finished our first 12-month program, and we had very significant outcomes with our staff, decreases in anxiety, decreases in perceived stress, increases in mindfulness, increases in calm, compassionate care, increases in providing non-pharmacological therapies. And so we are just beginning to present that research now, planning for our next cohort. But the next thing that we need to look at is then how is that translating to the patients and how people are bringing it to the patients. And it can be the smallest thing. You know, you have a patient who's stressed and you tell them, okay, I'm going to turn on my clock and we're going to breathe for 1 minute. Depending on the age, there's so many different techniques that focus on breathing or guided imagery for, you know, anyone from age 3 all the way up to the parents. So the next thing we're going to look at is how is this impacting patients, if at all, and if you had a provider who is more mindful and who can do these techniques with you and help you in really stressful moments, does that improve the patient's outcomes there, or their quality of life in some way? So the next step is going to be translating what the staff is bringing to the patients and how, and what that's showing. So that's sort of where we are. Do I have a minute left?
Yes.
Okay, everybody close your eyes. 1 minute. Get comfortable in your chair. And just find your breath. And just notice what it feels like as it comes in through your nose, into your belly, and as it comes back out again. And as those thoughts are flying by in your mind, that they will, just acknowledge that you're having a thought, and then bring it right back to your breath. Over and over again, however many times you need to do that. Just keep coming right back to your breath. You might want to try deepening your breath for a few breaths. Breathing in a little slower, breathing out a little slower. Okay. That was 1 short minute. But you just meditated. It's that simple. We try to teach people that some people are afraid to try it. They think that you would need an hour every day to do that in order for it to have benefit. But what the science is showing is that, and I think you said this too, if you can do what you just did 3 or 4 times a day, you're going to get a benefit. And if you notice that in your body that you are feeling sensations of stress, instead of just ignoring it and going, why is my head is pounding, why is my stomach churning? Instead of just ignoring it and running off and doing your million things, just stop for a second and do what you just did right now. And eventually you want to start doing it a little bit longer, but you will get the benefit, and it can be that simple, and you can do that with your patients as well. Amen.
So we're going to have some time for questions here. I'm just going to summarize what I think I heard, and you all can correct me if I'm wrong, just so we're all back on the same page. So Dr. Steinhorn talked about shamanic healing, and he talked about how that inner voice in our head can create chaos, you know, where our thoughts just go around and around and around. But even a few seconds of quiet, as Vicki just demonstrated, can really be quite calming. And we really don't have to learn anything new because we're hardwired to be mindful. And in thinking about our nonverbals when we're going in to see patients and families and how we can use that calming spirit ourselves to enhance the quality and life of the patients around us. Reese talked about acupuncture, and you'll see a lot of themes that ran across everybody's. Acupuncture is really being an art, and that each patient is treated as an individual, so it's very challenging to protocolize it. And there may also be even differences between the practitioners themselves, that many of the studies we see in acupuncture, the details are really lacking, like how often, how deep the needle was put in, how much stimulation, those kinds of things. But it can be used and be helpful in many different symptoms and in many different conditions. Marian talked about the dark side and woo-woo medicine, which I think actually is really, I'm glad that you said that, because that is, for some, that is what, you know, families hear and what they think. But that she also talked about each patient being very different and having to follow the energy of the patient in doing her healing. Thinking about the purity of the products we're using, and that all those things just off the shelf may not be exactly what we want to use and get the best benefit. Aromatherapy, raising the vibrational energy, and I'm going to have you to ask more about that. That was fascinating. But also remembering that smells can be triggers for memories and events. And so she made a good point about using multiple scents at a time, so they're often not, one scent is not necessarily associated with a certain memory. And that some of the research studies into aromatherapy don't compare apples to apples. You know, they're comparing apples and oranges. So how can you really then make a statement about what the outcomes were? And that we often lack controls and then policies for those. Carrie, talking about massage, she also acknowledges there's a lot of overlap between modalities, and also talking about the patient running the show. Again, is that every individual is different. Very helpful in decreasing pain and anxiety, and I'm going to be on their sleep study. They've done a dosing study, really, or doing it now, I guess, right? The dosing study about how frequently, how long, you know, those kinds of things. And I thought she made a really good point about some people will say that the massage wore off, you know, the effects of the massage wore off, and that morphine, too, is only a temporary thing. Morphine, one dose of morphine doesn't last forever. And then it can be very, you also made a statement that I didn't quite appreciate until you said it, even though I think it. It's very empowering for a patient and family to say no, because so many practitioners are coming in and out of their room, and they have no choice about whether they want that treatment, that medicine, whatever, and this is a therapy that they can say no to, really can say no to any of these. And then Vicki brought us full circle again, talking about needing to tailor to the needs of an individual. I'm very curious to hear how you achieved 100% completion in your study, other than your really great person.
That one was only 10.
Oh. And if there's many adult studies of mindfulness-based stress reduction, including randomized clinical trials, so that's really awesome for the science, because it helps us gain credibility in medicine and having really rigorous studies showing an effect. But as providers, we also need to know how to handle our own stress. And she talked about our Mindful Mentors program and being able to just take that minute and stop and, you know, do the calming healing for yourself so that you can be a more effective healer for your patient. So in the last 15 minutes or so, I want to open it up to questions to you guys for any of our panelists, either about their modality, about the science. I'm really interested in, we are really interested in hearing your thoughts of how can we improve the rigor of science in studying its modalities, because I think our panelists brought up some really good points and how we know it works. We've seen it work with individual patients. How do we prove that in sort of a scientific way? So, solve that problem for us. Yeah, go ahead.
I went to a community, I'm Brenda Martin, and I had the big task of working with some patients with chronic pain. So I went to a community meeting where they had providers, social workers, insurance companies, everybody talking about the opioid crisis. And one of the things that I brought up was dealing with chronic pain and trying to get these modalities for them to pay for it. And the one thing was Blue Cross Blue Shield who said to me, you have to prove it to me.
Yeah.
And so we do need these studies. We're now doing an acupuncture study with sickle cell children as inpatient. And what we're doing is that we have Lucy, who is giving acupuncture for those who say yes, and then we have a control group. And we're trying to look to see, can we give less medication, less opioids? Can we decrease the length of stay? And it's just a pilot study, but if it does work, this is what the insurance companies are asking for us to get these modalities, because they get it inpatient. But what do we do when we send them out? What happens? They go back to the medication because we can't get this.
Well, and I think you make a really good point, because one of the things that I feel really passionately is lacking in all of the kind of integrative therapy studies is we're constantly being pressured to, like, use a control that doesn't really make any sense, like massage versus yoga, acupuncture versus sham acupuncture. Like, nobody's getting sham acupuncture as standard care. Nobody is getting yoga as standard care. These aren't programs that are here. They're getting opioids, or they're getting nothing, right? And so I think when we design these studies, there's a huge amount of pressure to come up with this control that's sort of a thing that we insert that isn't really, what are you actually trying to do? Lessen opioid use, or, lessen, whatever.
Thank you all for participating, and thanks for everybody coming. This is really great turnout, and it's so interesting to learn about all that's going on in the hospital that I wasn't aware of. I'm Randy Strickson, a psychologist here, and I spent a lot of time doing research. I wanted to comment on the research and then clinical. I think that since there hasn't been a whole lot of research in the pediatric population, as Brenda just pointed out, anything that you do in a pilot way is going to contribute and maybe be the seed for something that's going to come further along. I was thinking a lot about psychological interventions and how you all talked about how you can't protocolize everything, that there's a little bit of an art and you have to tailor to the patient, and a lot of the work in psychotherapy is similar. So some interventions might be more specific, like there's a cognitive behavioral treatment for insomnia that you might do to see if insomnia, resolves, but you might have to do a little bit more tweaking to tailor it. But a lot of other therapies, it's less protocol, and yet there's still a good body of research that is able to demonstrate, compared to usual care or, no intervention, that there is a benefit. So I think I wouldn't worry so much that what you do is an art. I wouldn't change it, but I think comparing it to people who didn't get it, or looking pre and post, did their symptoms change after they took the intervention, I think would still be a huge benefit. So I would stress less about having it be just by the book and just get some data, because people like the providers, the insurance companies, are going to want to see, does this really, is this a benefit to us? And then I had a question about the clinical side of things. I understand a number of you work with the Attendees program, and that's really nice that there's so much integrative therapies there. But I wondered, and I know, Vicki is in cardiology, but I wonder how much you work with other specialty divisions here, specialty services at the hospital, and if you see groups that would really benefit from you, but you haven't gotten any traction to get in. And what about mental health? Do any of you work? Do any of you work with mental health? Specific groups.
All right, Lauren, do you want to take a stab at that?
Sure. I want to say first that I think we really devalue and don't do justice to the way these things can be perceived when we call them modalities. When we start talking about massage therapy as a discipline and acupuncture as a discipline, there's a greater trust in the practitioners that's conferred with that, and that it's not just, I'm going to rub. I'm going to learn about your condition and all of the psychosocial aspects and the whole, total pain picture, as they talk about in palliative care, so that I can use everything I know within this giant umbrella that might include craniosacral, that might include Swedish, that might include all these other things. And that if we keep talking about them as modalities, it's really easy for people to think, well, I could teach a nurse to do this. Yeah, you could teach a nurse to do this, but a nurse is not a massage therapist, and the nurse has plenty to do. So I think we really need to look at that, and we also need to look at, we'd love to be everywhere in the hospital, but when we show up, you're going to volunteer, right? And that we can't show the real value in studies where we get 2 massages, or you get 2 acupuncture treatments. I mean, acupuncture in particular, you get 15 or 20 before you really start to see. And so I think there's a real lack of understanding about, and an imbalance in what's expected of us in creating data. We've shown that it works, and what we've shown that's even more important is that it's safe, which is more than we can say about things that are standard of care in any hospital. So I feel like we're chasing this data. We still don't know how aspirin works. So I think we have to really hold our ground and say, this is what's useful to show. We're not like the other things in mainstream care, so we can't measure them and we can't create studies like the other studies.
Who are you, Lauren?
Lauren Tate, sorry. I'm the Executive Director of Heal Well and Massage Therapist.
So can you say, what other groups do you do your services?
So I work at the pain clinic. And I have a lot of, case studies of like a young girl with chronic headaches, multiple ER admissions, multiple admissions to the hospital. And after 2 years, she now no longer comes here, no longer has ER admissions, no longer has decreased her medicine in half. Yes, she's still on medicine, but she's not routinely coming in here every month, every week, every other week. And I have several studies of case incidences of things like that. But how do you take a child like that and put them in a study, you know, compared to other? So I think I work with the pain clinic, I work with anesthesia, I work with pre-op as well as, so a lot of times I get very anxious children, and I quickly either teach them how to meditate, do a little mindfulness with them, or do a little, you know, EFT with them to help them get rid of their fears. I do a little healing touch with them. I teach the nurses or the parents how to do a little healing touch post-operatively, and sometimes I use aromatherapy. So I'm, you know, between all those, it's like I feel like sometimes I bounce all over the place. But it's just me. I'm trying to get lots of other people to do it.
We work here with the hematology oncology team, the health team, and the PANDA team. And at different facilities, we work with different teams. But mostly it's palliative care because mostly that's where we get money for our program.
So Dr. Steinhorn, do you want to talk a little bit, or are we in a position yet to talk about sort of the hospital-wide integrative therapy?
I wanted to address this issue.
Okay.
You're asking for proof and you're talking about science. Yes, Randy, you.
No, I don't think I'm asking for proof. I'm just saying you all presented, or at least Reese started, like you couldn't do research, and I was just saying you actually could. I was saying not to be frightened by it had to be perfect, because I don't believe that. And Brenda had mentioned that the insurance companies are asking. I always think as a researcher that you could find a way to do research. But I think I'm a believer, so I'm not in that camp that it needs it, but I think for people to pay for it, like the hospital, yes, I understand that they want to see more demonstrated of this population.
Many of us believe in psychological support too,
Right.
although that's limited by economic factors of this institution. Both the sickle cell population, which is a beautiful, discrete population that's a kind of controlled entity in disease, and that's why I think that is such a powerful and important program to explore these modalities and look at some objective outcomes, less narcotic use and those sorts of things. I think that people need to realize that what you've heard from everybody up here is that I don't want to go to the art part, but I want to go to the intention, because the intention that you hold in your heart may be deeper down in your body than your heart, but not just from your head, is so powerful in terms of nuancing your interaction with the individual. People have always wondered, is massage therapy simply a manipulative modality where you move tissues around and increase blood flow and stuff, or is there a strong component of the personal presence of a caring, compassionate individual? That's what's missing in the hospital. True compassion, true expression of compassion and caring and concern for another human being. You may not believe it, but trust me, you go to the ICUs and you see how these patients are treated. We round outside the rooms, the patients over there. And we don't have enough real appreciation for the value of human connection and compassion. And that's a big part of what's missing, and why I, as a very hard scientific-based guy who's grown cells and killed lots of little rodents in the lab, love that stuff for the science of it, but it doesn't feed my heart or my soul. And the only thing that can feed my heart and soul is when I'm being compassionate, helping other person. So in order to achieve that, we need to have sufficient economic financial support, to have enough qualified and trained practitioners with expertise in pediatrics in particular, because the developmental aspects of all of these disciplines actually may impact how the patient receives the modality, and you can't use a geriatric massage therapist necessarily for a 2-month-old. And the same thing for a lot of the other skills. So we are building currently an initiative under Martha Pera's leadership that will hopefully provide massage, acupuncture, aromatherapy, energy healing techniques, whether it's healing touch or other techniques. What else are you going to bring in there? that therapy is going to be in there. These other sort of mindfulness, these kind of nonverbal, non-cognitive ways of connecting with another person. I think guided imagery is a good example of what you can do with young children in terms of bringing them to a peaceful place. I had a case study that we did of a child with renal failure and pulmonary hemorrhage where it was incredibly valuable. And we won't be able to use exactly the same scientific methodologies to answer the questions that Western science and medicine uses because the Renaissance and the Age of Enlightenment separated the body from the soul. And when that happened, the church owned and kept possession of the soul and said to the scientists and physicians, you can do what you want with the body because we own the soul. Now, this is true medical history, and it's only now in this 21st century that people are recognizing the tremendous absence of actual connection with the fragile human being inside these sick bodies that we care for. And that's, I think, what these modalities, these disciplines, allow us to begin to approach in a way that the patients and families perceive, feel, and benefit from. But all we have right now is satisfaction surveys and those sorts of things. Tiffany Fields, a massage therapy for infants showed increased weight gain in premature babies and all sorts of stuff like that, better self-regulation and those sorts of things. But that was now 20 years ago. And we haven't moved that much beyond that at this point in terms of many of these disciplines. And the last thing I want to say is that NIH, through the Center for Complementary and Alternative Medicine, which is now turned into something in integrative medicine or something, expended tens of billions of dollars in research that was vetted by peers and scientifically valid individuals and did not produce as much meaningful data as they were hoping for, and as a result, they've really shifted their focus away from some of these modalities such as energy healing and aroma and things like that, and they're focusing on other things, some of which will address the opioid crisis as a big priority. But I think that your program with the sickle cell patients, with Layla and the others, I think will be a very powerful.
Sickle cell pain clinic where we have most of these modalities for physical therapy from us. But, just like you said, money. Well, one thing that I am doing is telling the parents, you have to be with me. You have to be my advocate. You have to talk to your insurance company. And I got one family to get the insurance company to pay for massage. But it's again and again, yeah.
So I want to thank each one of our panelists. I think they were awesome. Let's please give them a round of applause. Hopefully you heard that while the science is not what we typically think about when designing bench research, even small pilot studies can contribute to the science. And I think your point about looking at some of the cognitive behavioral studies can be important to us in thinking about how to design and how to measure the effect and comparing to usual care. And then thinking about words matter and calling these things treatments and disciplines instead of modalities or woo-woo medicine. Please don't use woo-woo medicine with an insurance company. I'm thinking about our intention, and you can do small things. One of the things I do when I'm going in to see a patient and family, before I go in the room, I put my hand on the door, and I just internally, say a little prayer to myself, to give me the wisdom to deal with that patient. That's mindfulness. So even that's 2 seconds, of even God help me, whatever it is, can be intentional. So thank you all for coming. We'll let you know when we get the $1 million endowment.